Good morning, ladies and gentlemen. Thank you very much for joining us here this morning for the inherited metabolic diseases session. It's actually more like a lysosomal storage disease session, which is the same thing. But thanks very much to you, but also to the organizers, Russell at the back, for inviting us and giving us the opportunity to talk to you about this generally rare but very important group of disorders. So these are my disclosures in the field of lysosomal storage disorders on developing different therapies. I've been involved in this for the last 20 years or so. So this is what I'm going to talk about over the next half an hour or so. I will give you a general introduction on the lysosomal disorders, what they are, a bit about the pathology, what's the underlying mechanisms, a bit more about the groups, what are the different groups of lysosomal storage disorders, and then focus on the neurodegenerative types of the lysosomal storage disorders. Again, what are the typical clinical features, presentation, differential diagnosis, how we diagnose them, why we need to diagnose them, a bit about treatments, management, and I'll give an example of a particular lysosomal storage disorder where it's very, very clear why the early diagnosis could really make a big difference to the lives of the patients themselves and the families. And then basically the conclusions and the main points. So the lysosomal storage disorders are individually extremely rare, and some of them are as rare as 1 in a million or even rarer than that. Some are a bit more common. But as a group, they altogether, there's more than 70 disorders that have been described now. Actually, as a group, the incidence is about 1 in 5,000 births, depending on which population you're talking about. And of course, within each of these disorders, there is a variability of the phenotype. Some of them present in the infancy, and some of them can present in much older age, in adults. On the whole, the lysosomal storage disorders present as enzyme defects, which is a large group, more than 40 disorders or so. And then some of them are also lysosomal proteins, but they may have a different function. For example, they're in transmembrane proteins. Some of them we know the function, what they particularly transport a protein, but for some of them we don't actually know what they do. And then there are other proteins that may be involved in trafficking of different molecules around the cell. And essentially what the common theme in all these disorders is the storage of molecules in the lysosomal compartment. So these are different molecules and depends on which type of disorders these are. Lysosomes are very important for human cells. And because of that, these disorders are typically multi-system. However, they're not all completely multi-system. Some of them are focusing on the disease is in a particular system, skeletal, for example. Many of them affect the brain. There are now therapies available for some of these disorders. Particularly the enzyme replacement therapy became available for Gaucher disease in the 1990s. And that is an extremely successful example of the therapy that is very specific, personalized therapy for that disease. And other enzyme replacement therapies were developed as a result of that. There are now other types of treatments, for example, substrate reduction therapies, where it stops the accumulation of the offending molecules in a different way. It doesn't replace the enzyme, but it might be blocking the enzyme higher up in the pathway, preventing the accumulation of these molecules. And then more recently, the gene therapy is starting to come in. For example, the one we're going to talk about is metachromatic leukodystrophy, where essentially the bone marrow transplantation has been tested in some of the groups, and the ex vivo gene therapy is a bit like bone marrow transplantation, but in a different way, where you retransplant the same cells to the same patient, their own cells. So, however, unfortunately, many of the lysosomal storage disorders don't have any therapies, and we need more of those developed. Some of them, there are therapies, but they're not really curative in any shape or form. They're not really that effective, and we need better treatments for many of them. I want to focus, at least for 1 minute, on the importance of early diagnosis. Why do we need to do that? I don't think in the past, sort of making a diagnosis was a lot more difficult anyway. You had to send tests to very specialized centers. Nowadays, it's a bit easier when you are able to order the genetics test. So for some patients, you can do it. But people really, well, we as clinicians perhaps didn't think about the urgency of the diagnosis. So why would we want to do it particularly early? So for many disorders where there is still no treatment, it's still important to make the diagnosis, because this will help giving accurate prognosis for the family, help them to make the right reproductive choices, potentially preventing future new patients being born, but also you can shorten this horrible long diagnostic odyssey for the family, where they have to come for new tests. Nobody knows what's wrong with this child. They're deteriorating, and you can't really give right prognosis. And importantly, for us as clinicians, is to pick up these patients early on in the disease progress, because for many of these disorders, particularly neurodegenerative disorders, what's lost cannot really be replaced. So where we can't really give a brain transplant. So in patients where there is a progressive atrophy of parts of the brain, even when there is treatment available, you can modify the disease process, but you can't really reverse it in these sort of disorders anyway. So it's really important to do that. So what are the challenges? I think the challenges are relatively obvious. Individually, they're rare. So for a general pediatricians, they don't necessarily have to know all of these diseases. It's difficult to think about them, even though as a group they are common. It's quite difficult to think about individual disease and start diagnosing them. I think from that point of view, actually the advent of next generation sequencing, where you can get panels of genes done, at least in some countries anyway, but where it is available, you don't need to necessarily think, oh, there is that disorder, or there is the fucosidosis that I've never heard of, or some other disorder that's MPS plus, that are some new disorder, because we learn about new disorders every year. So actually, if you do a panel, it will hopefully diagnose at least the simpler ones. This is the positive of this. And I guess if you don't think about diagnosing these disorders, you're not going to diagnose it if you need to send a specific test for each of them. That's different. The other thing is, obviously, if you think about specific phenotype, you may come up with something that is unexpected. So, as I said, all of the conditions can be presenting at different ages with slightly different presenting features. So, if you think that, for example, mucolipidosis should all be presenting really early with a typical eye cell phenotype, well, you may actually diagnose patients that can present much later with a different phenotype, and that happens. Batten disease, you think they should be presenting in the first few years of life with seizures and dementing illness, but they can actually present in much older childhood with no eye phenotype at all. So these may be confusing clinicians as well. So globally, how important that is? Well, so to manage the patients, as any multisystem disorder, is complex, and it is a complex approach that is really important. So you have multidisciplinary, many clinicians often need to be involved. Take any disease, for example, MPS, mucopolysaccharidosis. You have, as well as the biochemical geneticists or metabolic physicians like us involved, you also have the, for example, if they had a bone marrow transplant, you have a bone marrow transplanters involved. You have the orthopedic surgeons often involved, sometimes neurologists. And the community pediatrics is really important to be involved as well. For example, if the patients that need to have enzyme replacement therapy, nowadays, this is done in the community. So very much the local nurses, clinical team are involved in that. Many innovative therapies first are tested, developed for rare disorders, and for many lysosomal storage disorders where you have these new amazing therapies like gene therapies, effective or not effective, but they're first developed for these rare disorders, and then technology can move on and perhaps go on to more common disease. Example being Gaucher disease. So Gaucher disease is, there are several types. We can talk a little bit about it, but there is a neurodegenerative type, and then there is a type 1 where they're not supposed to have neurodegeneration. But it's been, in the last 15 years or so, it's been clearly shown that being heterozygous for mutations in the same gene as involved in Gaucher disease actually strongly predisposes you to developing Parkinson's disease. So there are now clinical trials of gene therapy for the GBA. The same gene is given to the patients with Parkinson's disease. It's tested. We don't know whether it's going to be successful or not, but essentially the same technologies go into common disease. These are very expensive therapies, and this could potentially be seen as a burden to the healthcare in any country. So some innovative approaches will need to be developed if these therapies come in for newer and newer disorders, because somebody has to pay. And there is only so much money that the government can raise in taxes. So something needs to be developed there, where gene therapies or enzyme replacement therapies cost millions for each patient. This is an important thing, and as I already mentioned, the research. So in terms of inheritance of these disorders, the vast majority of them are autosomal recessive. There are a couple that I can think of that are inherited in X-linked recessive way. I can't think of any dominant disorders, but maybe I'm just not. Maybe there is a Batten disease where CLN11, where you have dominant disorder, but it's a slightly adult presenting condition. But most of them, vast majority, are recessive. So they would be associated with higher levels of consanguinity. So you would expect that we're in the areas where there is a high levels of consanguinity, there will be more of this disease present. So what are the subclasses? So the subclasses of LSDs depend on, so they're split in various ways. Generally, they are split depending on what sort of molecule is accumulating. But not only. So here I have sphingolipidoses. So sphingolipids are a particular type of fats that are really important for the membrane. So they are parts of the membranes, particularly in the brain cells. So the sphingolipidoses, we'll talk about those. mucopolysaccharidosis, where you have the MPS or GAGs, glycosamine or glycans accumulating. So these are the large molecules with sugar and proteins in them, and they are important for the connective tissue. So this is mainly connective tissue disorder, but also some of the types are neurodegenerative. Glycoproteinosis include various, basically these are disorders of protein glycosylation. So such as alpha mannosidosis, beta mannosidosis, and others like that. Lipid storage, I made it a little bit brighter here because actually this is not a neurodegenerative group of disorders, the lysosomal acid lipase, and glycogen storage disease type 2, Pompe disease, sort of doesn't fit in there, but also not a neurodegenerative LSD. There are post-translational modification defects, and these are mucolipidosis, particularly, and multiple sulfatase deficiency, integral membrane proteins that are linked into the particularly protein trafficking or other molecule lipid trafficking as well, with NCLs really do fit into a few of those. So although it's taken as a separate group, really some of them are integral membrane proteins, some of them are enzymes. So a bit about pathophysiology of lysosomal storage disorders, and a lot of research has been done. We understand a lot, but there is still quite a bit we don't understand. So what do we know? We know that there is impaired autophagy and also specifically mitophagy. So autophagy is an important process of cell and tissue renewal, where essentially cells undergo programmed death and also get rid of not just the whole cell, but maybe some part of it. Like mitophagy, you get rid of the mitochondria that need to be essentially expunged or renewed in the cells. There is a toxic effect of the substrate accumulation, so that could disrupt cell membranes, disrupt the signaling, cell signaling. Inflammation is very important, and there is now quite a bit of work done that if you reduce the inflammation, particularly in relevant to the neurodegenerative disorders, if you reduce neuroinflammation, you can change the course of the disease. So not only the specific enzyme replacement therapies, but drugs that reduce neuroinflammation can be effective. ER stress, so again, that's related for the protein homeostasis within the cells, disruption of lysosomal signaling. So lysosomes are not just the organelles that destroy things, they also signal, and in response to the availability of different molecules within the cell. So that could be disrupted. Axonal transport defects. So this is, as you know, they are the neurons, the neuronal cells have very long axons, and it's the transport of molecules along the axons can be affected in the lysosomal storage disorders, and that of course will affect development, function of the neuronal tissue. Secondary lipid and protein accumulation. I think we are now maybe understanding the importance of that a bit more than before. So not only, if you have an enzyme deficiency, it's quite obvious that, logically, that if that enzyme is not there, then the substrate for that enzyme is going to be accumulating. So you need to replace the enzyme in order for the substrate to be somehow processed. But actually, as well as that, you have accumulating other molecules. So, for example, in the Batten disease, in neuronal steroid lipofuscinosis, typically you have accumulation of protein, but in addition to that, you may have accumulation of sphingolipids, which can be causing at least partially disease phenotype. So there are studies showing that if you prevent accumulation of these particular lipids, you may be able to affect in a positive way the phenotype. Excitotoxicity, so you have excitation of the parts of the brain where you don't want that to happen. So first of all, just a reminder that not all LSDs are neurodegenerative, and there are some conditions that do not affect brain function. So it's important that we don't treat all patients that they have some cognitive or neurological deficit. We shouldn't do that anyway, but actually here you have somebody with a Morquio syndrome, APS type 4, which is a very severe sort of disease. It's a mucopolysaccharidosis. There is accumulation of gags, but it's affecting connective tissues, not the brain. What you see here is actually some typical features of MPS and some of the other lysosomal storage disorders. So here you see the typical gibbous at the thoracolumbar junction, the odontoid hypoplasia or aplasia here, which is dangerous, so they can have dislocation of the whole head, so to speak, cranium, which can have fatal consequences. In this particular disease, these patients have macrocephaly, but actually cognitively they're normal. They can be very bright and very functional. This is a condition that Natalie is going to talk about. I just quickly mentioned alpha-mannosidosis. So this is one of the lysosomal storage disorders, and this is a combination of skeletal features and the neurodegeneration as well in this condition. But I'm not going to talk too much about it. So this a group of conditions where you can have a combination of neurodegeneration and visceromegaly. So these particularly conditions are Gaucher disease, specifically Gaucher disease type 2 and 3, where you have neurodegeneration, and the other ones would be Niemann-Pick disease, so Niemann-Pick disease type A, due to sphingomyelinase deficiency, Niemann-Pick type C, which is due to mutations in NPC1 or NPC2. So these are the sort of well-known disorders. Also neurodegeneration could be, you're okay. Neurodegeneration could be the main and sort of the unique feature of the condition. What do I have here? I have MLD, metachromatic leukodystrophy. I will talk a bit more about this condition later. No, this is Krabbe disease. Yeah, Krabbe disease. Apologies. Krabbe disease is another lysosomal storage disorder due to GAL-C defect. Can be variable presentation, typically presents in the first year of life. Very rapid progression of this disorder. Can be now treated. So there is a recommendation that we can treat it with bone marrow transplantation, particularly recommended that the bone marrow transplantation is done in the first 30 days of this child's life. So you have to diagnose them very early or antenatally. However, so here you see the globoid cells, and these are the typical leukodystrophy that can be detected on the MRI scan. There are some patients, however, that can present later in the juvenile form or even the adult onset. So need to be careful. The phenotype can be quite variable here. So first, the groups of disorders now I'm going to focus is this sphingolipidosis that have neurodegeneration. The particular sphingolipidosis that doesn't have neurodegeneration is Fabry disease. So we're not going to mention that. Farber disease is another one that isn't, unless it's presenting in the first sort of few months. The later presenting Farber is not neurodegenerative. So here we talk about Gaucher again, and as I mentioned earlier, this is due to glucocerebrosidase deficiency. How am I doing for time? Not too bad. Okay, glucocerebrosidase deficiency. There are 3 types, and then there are some intermediate types. So the most common is the type 1, which is not neurodegenerative, and there are lots of patients with that disorder. And this is the best example of enzyme replacement therapy because it's essentially a visceral disease. Unfortunately, at the moment, there are no approved treatments apart from miglustat, which is not also approved for 2 and 3. So the type 2 is the rapidly progressing neurodegenerative disorder, typically presents in the first year of life, and these patients typically die by the 3rd year of life. Type 3 is much more variable phenotype, and that's a combination of visceral and different sort of phenotype of the neurological disease. So there's loads of treatments that are being developed for this condition, as well as the enzyme replacement therapy. There are a number of gene therapy trials, both ex vivo and in vivo. So going down, there is a GM1 gangliosidosis due to beta-galactosidase deficiency. Again, I'll point you here that there are different subtypes, 1, 2, and 3, depends on when they present. GM2 gangliosidosis is famously known as 2 different disorders, one of which is Tay-Sachs disease after these clinicians, and that's due to alpha-hexosaminidase deficiency, and Sandhoff disease after Sandhoff, and that's a beta-hexosaminidase deficiency. Again, a variability in the phenotype here depending on age of presentation of this disease. Krabbe already mentioned. MLD, so metachromatic leukodystrophy, I'll talk about it a bit later. Niemann-Pick disease, so sphingomyelinase deficiency, it usually says A/B, but they're very different. So type A disease, typically presenting in the first year of life, similar to Gaucher type 2, very rapidly progressing disease, usually death by the age of 3. And then type B, very different, typically not neurodegenerative disorder. And then there is a mixture. So there are some patients present not in the first couple of years, later on, and they may have some features of the neurodegeneration as well as the features of the visceral disease. So it's really important to be careful at assessing different features of that phenotype. Sapacin deficiencies are extremely rare, and essentially you have one gene which encodes a pre-protein prosapacin, and depending on it provides a sort of a substrate. It's like a chaperone for the enzyme function, for many enzyme function, and depending on what specific enzyme part of that protein is affected, sort of the phenotype could be quite different. Quite a lot could be said about this. So this is a bit more on the pathway, and essentially what you see here is that the orange bit is the ceramide, which is the sort of a lipid part of the molecule, and these ones are sugar moieties, different ones, the glucose, galactose, and then the yellow bit is sialic acid. So at each step, when one sugar is taken off, if there is that enzyme is missing, it's associated with the disease. So you can have GM1, you have GM2 over here with Sandhoff, and so on. You have Krabbe disease, and then you have the Gaucher disease at different steps of the essentially removing different sugars. So if there is a problem with removing the sugar, there is accumulation of the substrate for that enzyme, but also additional substrates above. So a drug, so we talked about the substrate reduction therapy. So substrate reduction therapy started with miglustat, and what miglustat does, it sort of slows down. It doesn't completely abolish it, but slows down the production of the molecule that sits on top of it, of that pathway, and sort of minimizes the accumulation of all of these substrates. So in theory, it could work in many of these diseases. In practice, it's been approved for Gaucher disease type 1. It's also approved for Niemann-Pick type C disease, which is not in this pathway, but we know that although it is a cholesterol trafficking disorder, it's actually there is a number of sphingolipids accumulating in that disorder too. So reducing the accumulation of sphingolipids also has slowing down sort of effect in this disease. So I better hurry up a bit. So the next, I'm going to briefly talk about the mucopolysaccharidoses. Again, a group of disorders. Here I mentioned just the ones that are have neurodegeneration. So these are the MPS 1, Hurler, MPS 2, Hunter. Each of them, as the previously disorders described, have some variability in the phenotype. Here you have accumulation of these large molecules that are stored in the connective tissue in different organs. The glycoproteins or proteoglycans. So the commonest group here is probably the Sanfilippo or MPS type 3. There are 4 different MPS type 3 described. I think I'm right to say that they are probably the largest group of the MPS subtypes. Although we see, of course, the MPS 1, MPS 2. So Sanfilippo is predominantly presenting with neurodegeneration features. Important to pick it up. At the moment, as far as I know, there is no therapies that have been approved yet, but there are various trials, both of the enzyme replacement therapies and also gene therapies, ex vivo and in vivo, that are in progress for these disorders. MPS 7 SLE disease, very, very rare disorder. And as I said, important to remember, there is a spectrum of phenotypes. So some of them are obviously presenting with severe skeletal problems, but usually they actually develop over time. So the next group is glycoproteinosis, and Natalie is going to speak about the alpha-maltosidosis, but there are other disorders in that group, such as fucosidosis, aspartyl glucosaminidase deficiency, sialidosis, which again, there's a variability in all of these phenotypes. So this is quite scary because how do you diagnose them clinically? It's not easy. Galactosialidosis, where you have a deficiency of cathepsin A, again, a combination of skeletal features. So here I have the most severe type of fucosidosis, where you have both the skeletal, the brain MRI changes, and you have these angiokeratomas that you probably expect to see in Fabry disease, but you actually can't see them in some of the other lysosomal storage disorders. And this is this pathway where these again are different sugars, and the problem here is the modification of the protein. So if you have the deficiency of these enzymes, then you have accumulation and abnormal storage, particularly in the skeletal, but also in the brain. So next group, not too many disorders here, post-translational modification defects. So I include the multiple sulfatase deficiency, or SUMF, and this is this formal glycine generating enzyme, and also mucolipidosis, particularly the mucolipidosis type 2 or eye cell disease. And here's quite an old paper that shows the skeletal features of eye cell disease. Typically, they can be diagnosed at birth. This is very early presentation. In fact, these would be if an experienced antenatal sonographer could pick up the eye cell abnormalities. There is no therapies for this disorder yet. But the life expectancy now can be higher than you think. It was thought before, certainly, that they die by the age of 2, but there are some patients that live in 10 sort of teens, even with supporting care. I call these intracellular trafficking defects, something that you may not have heard, so-called MPS plus disorder. So this is these two proteins are not lysosomal proteins, but they are involved in formation of autophagosomes and lysosomes. So if you have a complete deficiency of these proteins, then you have a sort of a mixture of the lysosomal storage, and they are very severe. There is also a milder defect that have been found where these patients may just have ataxia. So difficult. The other ones, particularly here, is the Niemann-Pick type C disease, caused by either mutations in MPC1 or MPC2, and also mucolipidosis type 4, which is due to the deficiency of nucleolipin 1. And that's a transmembrane protein that sits in the lysosomal membrane and is involved in calcium signaling around the lysosome. So it causes the lysosomal dysfunction. I'm sorry, this is a busy slide, but that's all I have on the Batten disease, which of course is possibly the largest group of childhood dementia type of disorders. Classically, they have the 3 or 4, let's say, I think it's maybe 4, 3. So they have seizures, they have problems with pigmentary retinopathy and loss of sight. They have the loss of motor abilities and loss of cognitive abilities. So there's 4 features. That's classically that's how you put them together. They do have lysosomal storage. Typically, they have abnormal accumulation of the lipofuscin in the neurons, but also in other tissues, and could be diagnosed by electron microscopy of various tissues, including the blood. So, however, we do know now that on sequencing, we do find some cases where they may just have seizures, but nothing else. They may have eye phenotype, but nothing else. So actually, atypical forms have now been identified in most cases of these. The CLN11 or progranulin is known to be causing one forms of the adult sort of early onset dementia, and there is a gene therapy trial ongoing with this progranulin. I will quickly race through the rest perhaps. So presenting symptoms are typically could be the either developmental delay, typically global, or regression. So they may be progressive, often associated with other pathologies. Either they are neuro or extraneural pathologies. Seizures for some of the disorders, particularly the Batten disease, movement disorder certainly can be seen in many of these conditions, whether that's a stiffness or dystonias and curiform movements. Abnormal nerve conduction studies and electromyography could be identified. Patients could have behavioral abnormalities. For example, patients with Sanfilippo disease could be presenting with behavioral problems to start with. Very important to have the ophthalmology assessment. And yes, some of them classically known to have cherry red spot, particularly the sphingolipidosis. But so this is accumulation of pigment in a particular part of the retina. Pigmentary retinopathy, as I said, could be part of the Batten disease. Cataracts described in some of the disorders. Corneal clouding, of course, with MPS disorders. Ophthalmoplegia, Gaucher disease, Sandhoff, Tay-Sachs, NPC. Deafness could be part of, again, Sanfilippo of the MPS disorders. Brain MRI is essential. Think about doing brain MRI. Some of it could give you the diagnosis quickly. Typically, you would see symmetrical lesions. Some of them will be white matter, like Krabbe or metachromatic leukodystrophy, or some could be a mixture of gray and white matter. Skeletal abnormalities, for some disorders like MPS or alpha monocytosis, for example, described as dysostosis multiplex, so macrocephaly as well. Some disorders, I already talk about visceromegaly, dysmorphic coarse features for some of the conditions. So, of course, history and clinical examination is still the most important thing in our what we can do. And then following that, the testing depends on really availability of what in your country, in your hospital is available. So imaging tests, ideally brain MRI, skeletal survey, doing an abdominal ultrasound. You're doing blood tests. What I would do, certainly at some point, maybe relatively early, I would do the DNA test, and then whatever is available. To me, whole genome sequencing with panel is available, so I would do that. Blood film, you can find things that are important on blood film. Sending enzyme tests. So for me, what's available, they can do a whole panel of tests. That would be the lysosomal enzymes that will include all of the disorders, well, a lot of the disorders we talked about, particularly the enzymes anyway. Urine tests, you could do a mucopolysaccharides and oligosaccharides that will cover some of the conditions, but none of this is completely comprehensive. You need to think about this. For some conditions, the diagnosis is more difficult and biomarkers may be needed, such as Niemann-Pick type C disease, where genetics may be complicated to interpret, and a real sort of the important referrals, ophthalmology, cardiology, audiology could be important. So from the point of view of what other things this could be, I really sort of spent very brief time on that because there are so many different things. From the metabolic point of view, okay, so if it's a failure to thrive with neurological dysfunction, hepatomegaly, well, think about organic acidemias, urea cycle disorders, mitochondrial disorders. If these patients is hypotonia, hepatomegaly, some dysmorphism, well, these could be peroxisomal disorders, congenital disorders of glycosylation could be relevant. So there are specific tests for that. If the child has abnormal developmental progress and macrocephaly, from our point of view, Canavan's disease, important to think about, organic acidemias, Alexander's disease also, but that's probably a slightly different progress. So in terms of the additional investigations that I would do urine organic acids, plasma amino acids, ammonia, very long chain fatty acids for peroxisomal disorders, lactate, mitochondrial DNA possibly. So newborn screening is important, but unfortunately not available for LSDs in most countries. In some it is, but if we do have them, then we will be able to have better outcomes, at least in some disorders where there is treatment. But unfortunately, there is not too much of that. Most of them utilize enzyme assays and dry blood spots. There is a whole genome sequencing pilot in the UK at the moment. So in terms of management, important supportive care, important multidisciplinary approach and symptom management. And there are very few approved but specific therapies such as enzyme replacement therapy, SRT, substrate reduction therapy, and the gene therapy in MLD. So very briefly now about MLD. So in about 3 minutes, I think. MLD, it's an autosomal recessive disorder, and estimated birth prevalence about 1 in 40,000. It's caused by the deficiency of the enzyme called aryl sulfatase A. And there are different types. So it's a lysosomal enzyme. And what you have is an accumulation of sulfatides in multiple organs, but particularly central and peripheral nervous system. In addition, you have some visceral complications, but really the neurological disease is most important. As in all of the disorders, it's important again to remember that there is a spectrum of disease onset, and the earlier presenting disease is progressing faster under a slightly different presentation. So confusingly, the earliest presenting group is called late infantile. So what that means is they present before the age of 2.5 years. And this is typically a motor phenotype that progresses with the cognitive phenotype as well. And these patients, untreated, typically die by the age of 10 or so. And then you have, again, confusingly, the later presenting disease is actually called early, but juvenile. So these are the patients that present after the age of 2.5, from 2.5 till 6, and then you have late juvenile and adult. So the older presenting patients, so that after the sort of the adult adolescent presenting, they're more cognitive phenotype, and then the ones in the middle, they have a mixed motor and cognitive. So yes, this is a leukodystrophy. So you have a white matter abnormality, you have symmetrical disease, although in early patients, early on in the disease, they could be reported as normal. So ex vivo gene therapy is a specific therapy that is now approved both in Europe, and this year was approved by FDA as well. I think in the UK it was announced as the most expensive therapy that is around now. I don't know if that's still the case. That was a couple of years ago. Since then, there might have been more expensive things that came in. But essentially what happens is that this is the patient. They are given a drug to mobilize their bone marrow cells. They are then collected. Then the CD34 cells are so isolated. They are transduced, that's the word to use, where the gene therapy vector is being added to these cells that were collected from the patient. Then the cells are expanded into a bigger bag and then given back to the same patient. In the meantime, the patient gets chemotherapy, although it's a modified, maybe slightly lighter regimen of chemotherapy that they get in order to create a niche in the bone marrow that these cells can engraft. So that's essentially what happens. It works better than a bone marrow transplant. The bone marrow transplant can be now given to older presenting patients, but it really has little efficacy in the younger patients. So this is the trial that I probably skipped through. So this is the trial. It was an Italian group in Milan that performed the trial. Here, what shows that the patients, they looked at the brain MRI. The higher the number, the worse leukodystrophy is, and the darker dots are the patients that were treated. On the left, these are the patients with the earlier presenting disease, and you see that they did better, more stable MRI appearance. And here, the later presenting disease, and again, the darker dots are the ones who were treated. Here, and the lighter are the other ones. So what this shows that the brain MRI appearance stabilized, and here looking at the sort of motor impairment of death, and it shows what the treated patients were stabilized. This is the late infantile, meaning early present patients, and this is early juvenile, and again they did better if they were treated. So finally, Libmeldi is this drug that was approved, and essentially it's approved in children with late infantile and early juvenile forms of the disease. So what's the difference is that in the late infantile form, these patients have to be pre-symptomatic. So the only way you would treat these patients is if they're diagnosed on newborn screening. That doesn't exist yet. Or if there is already a sibling that has been diagnosed, and you diagnose this patient and you treat them as early as possible. The early juvenile form, they can be treated with early symptomatic. So they still should be able to walk, and the neurodegeneration hasn't yet set in. So sometimes it's quite difficult to, so their IQ has to be above 85. So this is my final slides. So it's important to recognize these patients early for the reasons I mentioned earlier. And I think this is an example where actually it makes a big difference to when you diagnose the patients. It's important to have a systematic diagnostic approach, or you're going to miss them. We're all going to miss them. Advancement in therapies are coming. There are clinical trials. There are some therapies already approved. So we hope that more and more diseases will have better prognosis. And it's important that these patients referred to the centers which have experience in treating. These are rare diseases, and the multidisciplinary approach is important. Thank you.